Good morning, everyone. Welcome you all once again in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj. I'm pediatrician by profession and teacher by passion. We are continuing our amazing series of INISS fast track revision neonatology. Uh, in this series, we have discussed many systems, many topics. Today we will discuss neonatal infections. This is very important topic. It will include bacterial infection, viral infection, and fungal infection. We'll discuss salient points of these topics. This will be actually high yield discussion, and this discussion is actually very focused on INISS exam. So again, I want your 100% attention in this class. Okay, and at least 5 to 6 questions in any form are expected out of it. Do share, like, and subscribe our channel. Without further delay, we'll start our discussion of neonatal infections. Okay, so neonatal infections will talk about bacterial infections which are more common. So, early onset neonatal sepsis. In this condition, the organism are two-third organism are gram negative. Okay, out of this, Acinetobacter is 22%, which is most common, and Klebsiella and E. coli are other one. One third are gram positive, that are Staph and Enterococcus. The most common organism in early onset sepsis, particularly in India, it is Acinetobacter, which is gram negative organism, one of the caution. So what are the risk factor of early onset neonatal sepsis? These are important for exam point of view as well as clinical practice point of view. Number one is spontaneous preterm labor in absence of PROM. This is first. Foul smelling liquor. This is second, like a pre-labor rupture of membrane, that is PROM more than 24 hours, confined or suspected intrauterine inflammation and infection, or both. That is called triple I. We'll discuss this triple I later also. This signifies intrauterine inflammation, infection, or both. Single uncleaned vaginal examination during labor. It is actually single is also considered as a risk factor. Prolonged labor. What is the definition of prolonged labor? Sum of first and second stage of labor is more than 24 hours. And severe perinatal asphyxia, that is Apgar score is less than 4 at 1 minute. So these are important. Examiner can ask all except question. So you have to remember all these parameter: 24 hours, triple I scenario, single examination, prolonged 24 hours, perinatal asphyxia, Apgar score less than 4 at 1 minute. Any question can be made out of it. So, early onset sepsis and late onset neonatal sepsis. In this condition, the age criteria, when it will be called as early, it is actually birth to 7 days of life, it will be called as early. Birth 7 days to 3 months of life, it will be called as late onset. Generally, we see in early onset respiratory problems are more. In late onset, CNS issues like sepsis, meningitis, osteoarthritis, fever, poor feeding, these are journal features. So early onset is more concerned with respiratory symptom, and late onset is more concerned with CNS symptoms. Okay, mode of transmission, obviously early onset in utero vertical and late onset nosocomial. GBS serotype, which is prominent GBS serotype. Actually, this is Western data, but for sake of remembering, 1A is more common in early onset and third is more common in late onset. Going forward to component of septic screen. So in our scenario, we'll discuss it also, how we'll proceed with septic screen. Just as of now, just see how septic screen components are there. The first component is absolute neutrophil counts. How you will see neutrophil count? That is, two charts are there. Manero charts for term neonate and Moisano chart for VLBW neonates. So this is very important. So absolute neutrophil counts are lowest at birth 1800. Okay, and at 12 hours of age, neutrophil count rises to 7,200. This is the peak point at 12 hours of age. After 12 hours of age, they are persistent at 1800 of count. So this is absolute neutrophil count. This is how they are actually getting varied by time after birth. But ultimately, Monero chart and Moigano chart were used for this absolute neutrophil count, term and preterm respectively. Okay, immature to total neutrophil ratio should be more than 0.2. Micro ESR should be more than 15 mm in first hour. Remember, this is not complete ESR. This is micro ESR. This should be more than 15 mm in first hour. CRP should be more than 1 milligram per liter. Okay, so all these criteria, absolute neutrophil count, IT ratio, micro ESR and CRP as a component of septic screen. If we talk about IT ratio, generally IT ratio is less than 0.16 at birth, but after 72 hours it is 0.12. So this is normal value after birth, after 72 hours. CRP cutoff is 0.6 to 0.8 milligram per liter, but for this septic screen to be positive, it should be more than 1 as we discussed here. Okay, procalcitonin, it is not used in septic screen because it's sensitive in specificity, but for sake of remembering, PCT peaks after 24 hours. Okay, so what is the mean range of PCT is 1.5 to 2.5, and total range, if we consider about PCT, it is 1 to 20 nanogram per ml. Okay, after 48 to 72 hours, PCT comes down to less than 0.5 nanogram per ml. Other factors are also used for septic workup, like they are in experimental phase, like serum amyloid A, hepcidin, CD64, CD11B, interleukin 1, interleukin 6, interleukin 8, TNF alpha, soluble TNF receptor, E-selectin, ICAM, etc. Okay, so actually I'm going very fast, but this is content dense and information dense video. Okay, many numerical question or fact based questions will be asked, so you have to be very well versed with these values like CRP value, PCT value, neutrophil count value. Okay, so stay with me, it will get sorted. Okay, going forward to a very important question in exam, in Viva, or in day-to-day practice also. When to do LP, lumbar puncture and neonatal sepsis. Okay, there are set guidelines for this. In early onset neonatal sepsis, if a neonate is asymptomatic, okay, but maternal risk factors are present. Okay, so you will do LP upfront? No. First you will do blood culture. If blood culture is positive, then do LP. Okay, but similar early onset sepsis neonate, which is symptomatic plus clinical feature suggestive of sepsis, do LP. Okay, and late onset sepsis, do lumbar puncture in all neonate. Why on all neonate? Because 1/3 of VLBW has negative blood culture, so LP is required. So in this slide you have actually seen LP is required in all cases of late onset sepsis, but only required in certain cases of early onset neonatal sepsis. What are those cases? Those are symptomatic plus clinical features, do LP, asymptomatic plus blood culture positive plus maternal infection, maternal risk factors are there, do lumbar puncture. Okay, these are clear cut guidelines. Okay, so there are normal parameters in term and preterm neonates. What are the cell count? What are the neutrophil count, CSF protein, and glucose? Okay, generally we'll discuss about term neonate first. Cells are normal is 8 cells are normal. but it can be range around 0 to 32. So we'll discussing term neonate 8 up to 8 cells is normal, but if you ask me range, it is 0 to 32. Okay, neutrophil count 60% is normal. CSF protein 90 around average is normal, but again limit should range should be there like 20 to 170. CSF glucose it is 52, range is 34 to 119. Okay, so this 8, 60%, 90 and 52 along with range, you have to remember all these figures. Okay, and range, if you don't want to remember, just remember absolute value. Just compare it with preterm very low birth weight neonates. Okay, so cell counts are 5, PMN are 8%, 60 to 8. CSF glucose is 148 and CSF protein is 148 and CSF glucose is 67. So these are normal in preterm. Okay, so again this is very important. Sorry, this is very important. In this scenario, we see 5, 8, 148 and 67. So these value we have to remember. Cell 8 to 5, PMN 60% to 8%, CSF protein 90 to 148 and CSF glucose is 52 to 67. You have to remember these values. Okay. CSF glucose estimation is not included in NNF guidelines. Okay, this is previous year question. In NNF doesn't value CSF glucose. Okay, so what are the indication or contraindication of lumbar puncture in neonates? Okay, this is also an important question. As we all know, indication any clinical feature suggestive of sepsis. We have discussed indication just before. Blood culture positive, yes. Late onset sepsis and clinical deterioration in any neonate after initial improvement. Okay, what are the contraindication of LP? They will ask what platelet count. Okay, generally we don't do LP in less than 50,000 of platelet count. Any coagulopathy, it is contraindication. Increased intracranial pressure, it is also contraindication. Cardiorespiratory instability is also contraindication, and local infection at lumbar puncture site is also contraindication. Going forward, what are the indication of starting antibiotics? When we will start antibiotic, so we'll discuss this as a flow chart form. So early onset sepsis and late onset sepsis. So in early onset sepsis, any one of criteria are met, start antibiotic. What are the any one out of four? Okay, first, more than three or more than three sepsis risk factors. We have discussed just some time back sepsis risk factors. Okay, if risk factors are three or more, just do a start antibiotic. Suspected or confirmed triple I, intrauterine inflammation, infection, or both. If it is found, just start antibiotic. If risk factors are only two or more than two, plus septic screen is positive, just start antibiotic. Okay, strong clinical suspicion of sepsis, start antibiotic. So okay, so in EOS you are not finding anything, but you have very strong clinical mind and you have very strong suspicion this neonate is in sepsis, just start antibiotic. If septic screen is positive, will you start antibiotic? No. Septic screen if positive with risk factors must be more than two or more than two. Okay, so septic screen positive along a note alone is not a indication of starting antibiotic. Triple I or more than three sepsis risk factor, there is no other thing required, just start this thing. Okay. LOS. In this condition, what happened? Late onset sepsis, strong clinical suspicion of sepsis, you can start. Septic screen is positive, you can start. Okay, just remember, if septic screen is positive in early onset sepsis, it is not alone criteria to start with antibiotics. You can't, you need risk factors, two or more risk factors. But if septic screen is positive in late onset neonatal sepsis, yes, start with antibiotics. Just remember this, understand this. Okay, Uh, Prophylactic antibiotics generally started in NICU units, which is generally not required. What guidelines say, if you're starting intravenous fluids, do not start antibiotics. If you're giving TPN, do not start. If your child is meconium aspiration syndrome, do not start. And if your child neonate is on exchange transfusion, don't start antibiotic. So antibiotic stewardship, antibiotic mentoring, antibiotic prescribing is very important to avoid possible antibiotic resistance in neonate and community. Okay. So next question will arise, if we are giving antibiotic to neonates, what is the ideal empiric antibiotic from your sick neonate? Okay, so basically the definitive antibiotic you will get after blood culture, but it will take some time. Till then you will start antibiotic. So what should be the antibiotic? Okay, so you have to do collect antibiogram and isolates for 6 to 12 months from your unit, from your hospital, or your from local area. Basically many institutes like premier institutes or many large nurseries do this, uh, have this antibiogram. They decide upon this this antibiogram is active in nurseries and other ICUs. Okay, so this antibiogram or isolate should be reviewed every 6 to 12 months. Okay, you got antibiogram, what you will do? You will start first line antibiotics. Okay, so these first line antibiotics, what is the definition of first line antibiotics? Because they will cover 60 to 70% of isolates. That's why this is called first line antibiotics. Second line antibiotics, it will cover 80% to 90% of isolates. This is how we'll proceed from first line to second line. Okay, one statement is there, it is PYQ also. What this state? Avoid cephalosporin in first line drugs. Why we should avoid cephalosporin? Because they induce ESBL organism, extended spectrum beta lactamase resistant, and they increase fungal colonization. So that's why cephalosporins are avoided as first line drugs in neonatal sepsis. Okay, some examples of empirical antibiotics to guide as a therapy. If organisms are community acquired and less resistance, you can go with MP plus genta, ampicillin plus gentamicin. If you found evidence of staph infection in your neonate, add cloxacillin, which is very obvious. Nosocomial infection, hospital acquired infection, if there no resistance is expected, just give beta lactam antibiotic alone. But if resistance is expected out of this flora, add aminoglycoside in beta lactam antibiotic. Okay, when you are suspecting pseudomonas, your go-to antibiotic will be piperacillin plus tazobactam plus amikacin. Piptaz and amica will be your drug of choice. If penicillin resistant staph is there, you will give cloxacillin, nefacillin and methicillin. Okay, methicillin resistant staph aureus, MRSA, all we know, will start with vancomycin, oxacillin plus aminoglycoside. Okay, next, enterococcus. This is very important. Enterococcus, the first line is MP plus genta and second line should be vanco. So don't use cephalosporins. That is the take home message out of this. Okay, listeria. MP plus genta is drug of choice. Cones, vancomycin is drug of choice. ESBL producing gram-negative organism, the drug of choice is carbapenem plus minus aminoglycosides. Okay, Enterobacter, Serratia, Pseudomonas, Citrobacter. Okay, if they are nosocomial, start with extended spectrum beta-lactam or cefepime and add aminoglycoside in it. Okay, and meningitis, it is carbapenem. Okay, so what you have to do, just pause this video and revise these again. These are empirical antibiotics of choice according to organism. Obviously after blood culture sensitivity we have to change your antibiotic and according to clinical condition of neonate. Okay, So, what are the reserve antibiotic? Is there any classification? Yes, we do. This is classification is called Awari classification by WHO. In this scenario, they have actually mentioned azithromycin, meropenem, and imipenem are reserved antibiotic. So, azithromycin is used in gram-negative organism. Meropenem is used in most pathogens except MRSA and Enterococcus. So in MRSA or Enterococcus, what is the main drug which is used now? It is vancomycin. That's why vancomycin plus meropenem, that is vanco and mero combination, is so popular in tertiary uh, care and ICU where newborns are sick. Okay, this is the rationale behind vanco plus mero combination. Imipenem. Okay, generally we should avoid this drug in newborn because of this is having seizure issue with neonates. Okay. So duration of antibiotic therapy, if started antibiotic, we choose antibiotic, how long we will give? Okay, if meningitis is there, so you have to give for 21 days, no discussion on it. Meningitis you have to give for 21 days. Blood culture is positive but no meningitis, 14 days. Okay, culture negative sepsis, 5 to 7 days. So just remember 1 week, 2 week and 3 week accordingly. Meningitis, blood culture positive, or clinical sepsis. This is uh, actually basic funda behind this. Okay. Are there any other therapies for neonatal sepsis apart from antibiotics? Yes, some exist, like exchange transfusion. So, what exchange transfusion done? This removes cytokinin bacterial products from blood circulation of neonate. Okay, so theoretically it must be important, but generally it is reserved and used in scleroderma and multiple organ failure. So these two indication you have to remember because they can be asked, like in scleroderma and multi-organ failure neonatal sepsis, exchange transfusion can be used. Immunotherapy generally have no benefit in neonatal sepsis. Lactoferrin. Okay, so what lactoferrin does? It decrease sepsis and it decrease NEC in VLBW neonates, but further studies again are required. Okay, so here with till now we have discussed neonatal sepsis. Just revise this neonatal sepsis again, and this is actually crux of neonatal sepsis. Many questions are expected out of it, like CSF, when to do LP, what are the findings, antibiotics, and risk factors, septic screen. Okay, now we'll forward to congenital viral infections, which are also very important. Okay, this top of the line table, you will see timing of infection is very important. Some infections are congenital, as we saw. Some are peripartum around birth, and some are postnatal. So, cytomegalo, rubello, parvo, Zika, LCMV are congenital infections, but peripartum like hepatitis C, B, HIV, varicella zoster, herpes simplex are more common in peripartum period. RSV, entero, adeno, rota, SARS, influenza are more common in infancy or postnatal. So timing is very important. We will discuss these infection, their protocols, their how you will proceed with these infection later also. Okay, as of now, this is clinical finding of some congenital viral infection. This is exhaustive looking table, but just stay focused with me. We'll discuss important thing. Okay, just see what I'm highlighting. Varicella zoster virus, it will cause limb hypoplasia, but very important. CMV will cause chronic villitis in placenta, but SARS will do acute villitis. Okay, this is important. Rubella will cause celery stalking with longitudinal demineralization. We'll discuss this along with X-ray picture of this particular finding later in this lecture. Microcephaly, so this is important. Examiner can ask which organism can cause microcephaly except. Okay, so CMV, Zika, Rubella, and LCMV, these are four organisms which causes microcephaly, very much important. Other like Aicardi syndrome, gem 3 mutation, NDE1 and ANKLE2 mutation also cause microcephaly, very much important. Intracranial calcification is again hot favorite topic of AIIMS examiner or INICT examiners. So all we know, CMV cause periventricular calcification, Zika causes parenchymal calcification, and Rubella cause basal ganglia calcification. Icardi syndrome and RNA-ACT2 mutation also cause intracranial calcification. So this table is exhaustive looking, but if you see some pointers here, these are potential question. You have to remember these only. Don't go through for whole table. Again, hearing loss, which is also important. Many organisms do hearing loss like CMV, Rubella, LCMV, HSV, VZV, mumps, measles, Zika, and genetic syndromes like GJB2 mutation, STRC mutation also cause this SN hearing loss. Okay, so this syndromatic approach or this can be asked in exam, all except question or statement based questions. Okay, thrombocytopenia. Are there infections which are causing thrombocytopenia? Very interesting, no? Yes. CMV, Rubella, HSV, and HIV cause thrombocytopenia. Other condition we know them clearly like Bernard-Soler syndrome, MYH9 mutations can also cause thrombocytopenia. Non-immune hydrops fetalis. All we know it is parvovirus B19, but along with parvovirus B19, CMV and rubella also causes non-immune hydrops fetalis. Hemolytic anemia again parvovirus B19 and CMV. Okay, cardiac abnormalities. So in this condition, rubella like PDA with pulmonary artery hypoplasia, parvovirus, B19 hypertrophic cardiopathy. So this is also one of the cause of cardiac abnormalities in neonate. Which infection causes myocarditis? Again, very much important, and it looks like potential MCQ in your upcoming exam. So what are those? In Coxsackie virus, parvovirus, enterovirus, very important. Congenital cataract, rubella, VZV and HSV, keratoconjunctivitis, HSV. Okay, skin lesion we have seen cicatrial lesions like VZV, varicose zoster virus. Okay, so some antiviral agents. We'll discuss antiviral agent use later in particular disease section. As of now, just remember acyclovir have many use. First, acyclovir is used in neonatal HSV infection and oral suppression following neonatal HSV infection. This was PYQ was asked. So in HSV we'll discuss it later also. First, actually you have to do acute management 20 milligram per kg per dose for 21 days and 14 days for SEM. We'll discuss it later also. And later you have to suppress it. So what will be the dose? 300 milligram per meter square per dose, 3 times a day, duration of therapy 6 months, and neutropenia is observed. So I'll discuss this under heading of HSV treatment management guideline, where we'll revise this acyclovir dosing again. So as of now, just remember it. Okay. Ganciclovir again 6 milligram per kg per dose, and Valganciclovir it is 16 milligram per kg per dose twice daily for 6 months. We'll discuss it also. And Oseltamivir it is infants less than 9 months 3 milligram per kg per dose, and other dose are mentioned. Okay, we'll discuss these particular doses in other sections. Okay. So this is again a very important section or actually table in front of you. Some organisms are very uncommon, but and their symptoms are not that commonly seen in neonates. But if they are very important for your exam point of view because they have certain keywords. You don't have to go for whole table. That's why I'm here to explain you to ease your understanding. What I'm doing, just stay with me. I will use some keywords from this table, and with keyword question appears in exam or in your clinical practice also, you have to remember these keywords. Okay, so Coxsackie B virus, this it generally cause heart failure in first week. So this is keyword heart failure in first week, Coxsackie B virus. Persistent myocardial dysfunction seen in 33 to 66% of patients of Coxsackie B virus. Similarly, HHV6 virus, you don't have to remember all this, but this cause possible neurodevelopmental concern with germline transmission. This is important. LCMV, lymphocytic cytomegalovirus. This spreads via rodent. Avoid rodent exposure in pregnancy. Okay, so this is the key. There should not be any rodent around pregnant women. LCMV will happen. Okay, if you can remember like this. Parvovirus having a risk of fetal hydrops. We have discussed it earlier also. Okay, varicella, skin lesions, limb hypoplasia, and eye abnormalities are important. And varicella can be prevented or pre-exposure prophylaxis. Basically, maternal vaccine is also considered. We'll discuss later regarding maternal vaccines also. Zika, we have discussed like Zika cause retinal abnormalities, hearing loss, okay, developmental delay, and so. Okay, so till now we have discussed congenital infections in nutshell in like tabular format. Now we'll discuss all these infections in one by one. We'll dissect them and we'll see their important implication in neonatal management of these conditions as well as clinical practice and exam point of view. Okay, so without further delay, let's start our discussion to individual disorders, perinatal HIV. This is like a favorite topic of every examiner, be it pediatric, be it NEET PG, NEET UG, or anything till your NEET SS examination. Okay, so breastfeeding. First question is that breastfeeding, is it required or having risk factors parental HIV? Risk is high in initial month of breastfeeding because viral load shedding is more in initial month of breastfeeding. Okay, so, but one important thing is there, if mother is taking effectively ART and compliance is good and is taking adequate doses with maternal RNA is less than 1000 RNA per ml, copy of maternal RNA is less than 1000 per ml, the risk is low, that is 0.25 to 2%. Okay, then we should give breastfeeding or not. Okay, for that, this to end this confusion, WHO proposed the criterias, guidelines basically. So, what WHO says, breastfeed for at least 12 months. Mother should be on ART and up to 2 years or more. So, basic WHO say, go for breastfeeding. Mother should be adequately on ART. Okay, you can go for feeding. Other feed, if mother feed is not available, mother is very sick, mother is not willing to give milk to her child, use AFAS criteria, affordability, feasibility, sustainability, etc. AFAS criteria is used. Okay, what is the mixed feeding guidelines? Means some mother is giving breastfeeding and baby is taking formula. So is it better? No, it is not better, but it is better than not having breastfeeding at all. Generally, in traditional teaching, mixed feeding is avoided, but WHO says कि if mother is not giving breastfeeding at all, it is better to give mix if it is the case scenario. Complementary feeding, as usual, should be started at 6 months of age. So this was about breastfeeding perinatal HIV. Okay, now one important question also arises, what should be the mode of delivery in perinatal HIV? So there are two guidelines like MTCT national guideline, mother to child transmission national guidelines, and WHO guidelines say there should be no elective LSCS in case of HIV patients unless any obstetric indications like asphyxia, other conditions are there. You can go for LSCS, but no, not as per se for HIV. So this is very important thing to consider. Okay, but some things we have to avoid while delivery, like normal delivery. Uh, Premature rupture of membrane should not be done. Okay, this is very important. Multiple vaginal examination should be avoided. Episiotomy should be avoided. Instrumental delivery should be avoided. Invasive fetal monitoring like fetal scalp pH monitoring should be avoided. Okay, so this is important. One PYQ also, if HIV RNA is less than 1000 copies per ml, PROM is not associated with increased risk of transmission. Okay, so again, in the mid of this discussion, I urge you to stay 100% here and give your 100% attention, because this is very, very important. These guidelines are actually need to be understood thoroughly and in tandem way. Okay, so what is the treatment regimen for treatment baby to mother in HIV? Okay, mother treatment, it is important to understand. NACO guidelines of 2021 says tenofovir, lamivudine and dolutegravir. Okay, so tenofovir is 300 mg, lamivudine is 300 mg, and dolutegravir is 50 mg, 300, 350. They should be given once a day for pregnancy and breastfeeding. That's all. Okay, TLD pneumonic and you can use for this. So these drugs are used for pregnancy and breastfeeding. This is the underlying thing or statement. This is very much important. Alternatives, you have to remember, don't have to use alternatives in general case scenario, but in exam they can ask this combination can be used or this combination can be not used. So tenofovir plus lamivudine plus efavirenz can be used. Zidovudine plus lamivudine efavirenz can be used. Zidovudine uh, Zidovudine, lamivudine, nevirapine can be used. Tenofovir, lamivudine and nevirapine can be used. So they can ask all these combination can be used, all except question in this case scenario. Okay, so you can answer them easily. So this slide is very much important. Going forward to, okay, again if you are just yawning or just sleeping, so stay awake. This is the most important slide of this entire discussion, entire lecture. So just give your 100% attention here. How to prevent transmission from mother to child, which is goal of our whole discussion. How to prevent. Okay, so just see if your infant or neonate is low risk or at high risk. How you will classify them at low risk or high risk. Okay, so low risk infant definition, just pay attention. If mother is taking ART regularly and adequately, she should be taking it regularly and on adequate doses. Okay, she should not miss doses, and doses should be adequate. Plus it is plus viral load is less than 1000 RNA copies per ml from 32-week till delivery. It should maintain that level. Okay, so viral load of HIV should be less than 1000 RNA copies per ml till when? Till delivery from 32 week of gestation. Very important. And she should be taking ART regularly and adequately. This is criteria of low risk infant in case of neonatal HIV. Okay, so uh, if then we will divide it. If the neonate is exclusively breastfeeding, okay, so you start with the nevirapine daily up to 6 weeks you have to give. If baby is low risk and is on exclusive breastfeed, just give him or her nevirapine daily for 6 weeks. We'll discuss nevirapine dose also, but as of now remember this. Okay, but if baby is on exclusively supplementary feed, extra feed other than breastfeeding, what you have to do? You have to give nevirapine, or you can use zidovudine. Zidovudine is given PD, nevirapine given daily. We'll discuss dose later also, up to 4 to 6 weeks. So, gross, if your infant is low risk, you can safely use nevirapine for 6 weeks in both cases if exclusive breastfeed or extra feed doesn't actually have any difference. This I want to convey. But if your neonate or infant at high risk, so what are the definition of high risk neonate infant in case of HIV? Mother not taking ART, it is high risk clear cut. But mother took ART less than 4 weeks, less than 1 month she took, it is high risk case. Mother having high viral load more than 1000 copies per ml from 32 week to delivery, it is high risk case. And mother is newly identified in pregnancy, both it is clearly high risk case. You have to think of this neonate or infant as high risk if she was newly identified in pregnancy, or if she was diagnosed within 6 weeks of delivery, you have to mark that neonate as high risk infant and neonate. Okay, so you have to remember these high risk and low risk infant, not for only for exam purpose, but as a responsible pediatrician neonatologist who is practicing at and managing these HIV positive or HIV infected children from mother. Okay, now going forward, then we will divide if the your neonate is exclusively breastfeed or exclusively replacement feed. If he or she is on exclusively breastfeed, uh, give him nevirapine daily, plus just pay attention, plus judovidine should be given BD. Okay, so dual therapy is given in high risk infant, very much important. And the for this, the duration is also doubled. Therapy drugs are also doubled, like 2, and duration is also doubled. At 12 week, you have to give till 12 week. Okay, but if your baby is on exclusive replacement feeds, you have to give nevirapine daily plus judovidine PD for 6 week only. So 12-week indication is for breastfeeding infant, which is high risk. So this can be asked. Okay, generally we continue nevirapine and judovidine till 6 week, but after 6 week, nevirapine can be used alone. So this is one of the modification which can be asked as case-based scenario. After 6 week, nevirapine alone can be used. Okay, just take a pause, just take a deep breathe. Okay, and just revise this flow chart once again. This is, and clear this once and for all. This is very much important. Okay. Now we'll discuss drugs as we discussed them in that flowchart. Okay, nevirapine dose we'll discuss first. So nevirapine dose, what is nevirapine dose? If your baby is okay, up to 6 week, what you will give? If your baby is less than 2 kg, the dose should be 2 milligram per kg per dose once a day. If your baby is 2 to 2.5 kg, 10 milligram OD will be the dose. And if your unit is more than 2.5 kg, 15 milligram per day is the dose. And after 6 weeks to up to 12 weeks, 20 milligram OD should be the dose. So this doses you have to remember: 2 milligram per kg, 10 milligram OD, 15 milligram and 20 milligram OD respectively. Okay, Judo dose as we discussed, 5 milligram per kg per dose BD, same less than 2 kg, 2 to 2.5 kg, 10 milligram per dose BD, more than 2.5 kg, 15 milligram per dose BD, and after 6 weeks, generally dose is not established for prophylaxis. So this is how you can remember this, and just remember nevirapine, judovidine syrup both having 1 ml 10 mg drug concentration in 1 ml of formulation. So this is this is also you have to remember. So that's how you will be well versed with dosing of nevirapine judovidine. Okay, so vaccination is also important question. In asymptomatic neonate, uh, you have to give all vaccines in that neonate or infant, no discussion. But your infant is symptomatic or immunosuppressed, you can still give all vaccine, except which vaccines we can't give in them: BCG we can't give, OPV can't give, and varicella we can't give in symptomatic and immunosuppressed patients. MMR is allowed in HIV infected infants, very much important. It is avoided in terminal stage where it is not given. HIV and pneumococcal, it is given in all infants. It is also important. Okay, so your baby is infected from like mother from HIV. We have discussed how we will uh, transmitted, what prophylaxis will given. So by considering the diagnosis of HIV along with prophylaxis and medicines, we'll discuss them in a single flow chart. Okay, just be with me, it is very important. Any baby is born to HIV infected mother. Clear? Okay. So consider nucleic acid test at birth or within 2 days. This is important. This is new addition. Okay. What it says ki you have to do nucleic acid testing at birth or within 2 days. Not should be done. Very much important. So you don't have to wait for 6 weeks and at all. You just do not within 2 days after, just after birth. Okay, but before this, what you have to do, just start nevirapine 2 milligram per kg per dose once a day at birth. Okay, and in like in low risk infant, and dual drug like nevirapine and zidovudine in high risk infant, which is very important. So any infant born out of HIV infected mother, without thinking anything, just start nevirapine or nevirapine plus zidovudine according to the condition. Okay, so after that we send sample for NET within 2 days or just after birth. So what will happen when it come out positive? So if it is coming positive, straightforward start ART and repeat NET to confirm infection. You have to start ART and you have to later keep confirming it by repeated test. But what happen if your NET is negative? Is HIV ruled out? No, my dear friend. It is not ruled out. What you have to do, HIV-1 DNA PCR or dried blood spot sampling test at 6 weeks of gestation. So you did at 2 days for birth, and after that DNA PCR or dried blood spot sampling at 6 weeks of gestation. If it comes out negative, will you rule out it? No, my dear friend. Just see what happened. Just I forgot. At 4 to 6 weeks of age, we start cotrimazole. All we know. Okay. Continue our discussion. Your HIV DNA PCR at 6 weeks is negative. So HIV is ruled out. Just wait, my dear friend. It's not that simple. Okay. In this condition, your cotrimazole prophylaxis will you started at 4 to 6 weeks. Continue it, but you have to stop nevirapine according to 6 to 12 weeks depending on the infant condition. Okay, so continue cotrimazole prophylaxis. Are we sorted ki we have found negative DNA PCR? No, we are not sorted yet. Repeat this HIV-1 DNA PCR or dried blood spot sampling at 9 months of age also. So negative test like 6 week we have done, and 9 month again we have to do because it is repeat. We can't afford to miss any positive cases. After it is negative at 9 months, are you sure? Just see what happened. In this condition, cotrimazole prophylaxis till HIV is excluded and continue breastfeeding till 2 years of age. So generally it is called negative, and after 1 to 2 year in practical scenario we also do repeat testing. So this ladder is used in negative patient, negative results of NET DNA PCR. So NET done at birth, DNA PCR is done at 6 weeks and 9 months to totally confirm this is negative case. Till then, the scheduled cotrimazole prophylaxis and scheduled prophylaxis of your nevirapine or zidovudine will continue. So that's how it is important. Okay, uh, we are in this limb now. If your first HIV DNA PCR at 6 weeks is positive, what will you do? In this condition, we'll send whole blood sample for HIV DNA PCR and we'll repeat this test because we have to be confirmed. After repeat, if it comes down positive, again you have to send another blood sample for confirming HIV PCR. In this condition, continue cotrimazole and start pediatric ART and continue till 2 years of age. Okay, so starting of ART indications. What are the ART indication? If your NAT is positive at birth, start ART. If your two HIV DNA PCR are positive, you have to send third sample also and start your ART. So after 3 times doing PCR, if it comes down to positive, you have to send, and if negative PCR, we have seen here, we have so here, sorry, negative PCR, 6 week and 9 month you have to do PCR in negative PCR case scenarios. Okay, so positive antibody screening, what we when you have to do at 18 months of age by 3 rapid tests. Breastfeeding, if it is continued, so do antibiotic screening after 3 months of stopping of breastfeeding. This is also PYQ. Okay, so this is actually a simplified classification of this complex looking flowchart. Just pause this video and revise these guidelines of diagnosis and prophylaxis of HIV in neonates or infant. It is very important. Okay, if your HIV positive infant is confirmed by HIV PCR by 3 times, you have to do start ART. So, what are the guidelines to start actually ART? Okay, if we don't start ART, it is said that 50% of infants die in within 2 years of age. That's how this is lethal disease in neonates. What is the combination? Judovidine plus lamivudine plus retiگravir or nevirapine. So this drug combination is used. It is used at 2 weeks of age. Very much important. After that, judovidine, lamivudine plus ritonavir booster is used. So this regime you have to remember. Till 2 week of age, the regime is slight bit different. After 2 week of age, the regime is slight bit different. Okay, so this you have to remember. It is ultra important. What are the FDA approved drug for infantile HIV treatment? These are Judovodine, Lamivudine, Nevirapine, Amicetrapine, and Raltegravir. So these are important. These are only 5 drugs which are approved by FDA. So examiner can ask which drug is not approved by FDA in all. Okay, so till now we have discussed neonatal or infantile HIV, how to prevent, what is the treatment, what is the prophylaxis guidelines. This is important. Okay, so you have to revise it once again. Okay, so going on forward, neonatal born to mother with tuberculosis. So now we'll discuss these guidelines as a flowchart base because this is easy to understand, and what is the crux are given in these flowcharts. Okay, so this flowchart start with mother diagnosed with tuberculosis during pregnancy or after delivery. We'll talk about during pregnancy or after delivery. So what you have to do, you have to see clinical evidence of congenital tuberculosis at birth. So what are the clinical evidence? These are respiratory distress, hepatosplenomegaly, lymphadenopathy, poor feeding and poor weight gain. Generally respiratory symptoms will be more. Okay. So, if clinical evidence of congenital TB are absent, you have to do chest X-ray and plus minus gastric aspirate. Gastric aspirate, if respiratory symptoms are there, you do gastric aspirate. If they are absent, don't do gastric aspirates. But X-ray is required. And if these clinical evidence of congenital TB are at birth are present, obviously you have to do chest X-ray, gastric aspirate, and USG abdominal lumbar puncture to see other sites also. So what we have learned in this condition of tuberculosis, just examine the child first. Second step, do chest X-ray. Okay, and if your neonate is symptomatic, do USG and lumbar puncture also. Till then it is clear. Okay, after that, uh, if you found any evidence of tuberculosis, like any evidence of tuberculosis, if you found in chest X-ray, gastric aspirate, or any evidence is the tuberculosis, start with your anti-tubercular treatment, that is 2-HRE plus 4-HRE. So this is the treatment regimen for starting anti-tubercular drug. Breastfeeding should be continued with cough hygiene, obviously. Okay, so now we are clear. We did X-ray, we found tuberculosis, we started treatment. What if there is no evidence of TB on X-ray, gastric spirit, and other things? So what you will do? Will you leave or discharge this neonate and send him or her at home? No. Will give BCG and start INH prophylaxis. Okay, this is important. INH prophylaxis and BCG should be given. So INH or BCG does not interfere in each other work, so you can give them simultaneously. Okay. After that discharging, call the neonatal infant after 4 to 6 weeks, and you have to see the clinical features of tuberculosis. If they are there, you have to do again diagnosis and start tuberculosis treatment. But if there is no evidence, so continue INH for 6 months. 6 months you have to continue INH. What is the dose of INH? It is 10 milligram per kg per day. So this is how X-ray along with plus minus gastric aspirate and USG. If it is positive, to start anti-tubercular treatment. If it is negative, just give BCG and start INH for 6 months. This is how we'll look this tuberculosis case. Okay. Next case is hepatitis B virus. Newborn born with mother of hepatitis B virus infection is also important. So what happened in this condition? Testing is recommended. So if a mother is hepatitis B positive, what you will give at birth? You will give hepatitis B vaccine. That is also important. Hepatitis B vaccine should be given in any case with hepatitis B immunoglobulin. What should be the dose? It is very important. 100 international units are given in different thighs. Okay, preferably within 12 hours, but not later than 48 to 72 hours. So along with vaccine, give hepatitis B immunoglobulin. The dose is 100 international units, and it should be given within 12 hours, but not later than 48 to 72 hours. This is the crux of this slide. Okay. After that, we have to continue HBV immunization. Okay. When you do follow-up testing or perform anti-HBs antibodies and HBsAg testing at birth, no, my dear friend, you will test at 9 to 12 months of age, around 1 year of age roughly, or you can be more precise, 9 to 12 months of age you will do HBsAg testing. If your anti-HBs titer is more than 10, you are all sorted, no further action is required. But your anti-HBs is less than 10 and HBsAg negative, means no infection is there, but your actually somehow your antibody levels are not adequate, so you have to repeat all your vaccination schedule of hepatitis B. But your HBsAg negative, HBsAg positive and anti-HBs is negative, so this is actually case of hepatitis B infection. Better to consult pediatric gastroenterologist, as they say, or any other infection person. So this will be treated accordingly, because regimen of this will be different. Okay. So this is the classical scenario hepatitis B. Just give vaccine and immunoglobulin. The dose is 100 international units in different thighs. If hepatitis immunoglobulin is not present, just give hepatitis immunoglobulin. That's it. Oh, sorry, hepatitis vaccine, that is. And testing of HbA1c should be done at 9 to 12 months of age, and according to the scenario, you have to proceed. So this is simplified flow chart of hepatitis B. Vertical transmission of HBsAg. If your patient is negative, it will be 5 to 20%. But if your patient is HB antigen positive, the chances are 70 to 90%, which is very higher. Vaccination prevents 70 to 90% of active immunization. Rest of immunity is given by immunoglobulin 10 to 30%. So that's why this statement is valid. If your hepatitis B immunoglobulin is not present, you can give vaccine alone also, because it will give 70 to 90% protection. Okay, so this is very important. Okay, so they say hepatitis B immunoglobulin within 12 hours to neonate with birth weight less than 2 kgs, and within 7 days of life to neonates birth weight more than 2 kgs. This is actually theoretical scenario. In practical scenario, just give hepatitis B immunoglobulin as soon as possible. Okay, next your infection is hepatitis C virus. Okay, so generally we don't know how to actually prevent this hepatitis C virus, so there is no guidelines as such. Mode of delivery also doesn't have any effect on this hepatitis C transmission. Exclusive breastfeeding you have to give. Breastfeeding is not contraindicated in hepatitis C virus. So follow-up testing, when you will do follow-up testing? So at 1 month, 6 months, 6 week, no my dear friend. This should be done in 18 month of age. This is PYQ, NEET SS PYQ. Actually 18 month of age we have to do testing. This is important. Okay. If it is negative at 18 months, just rule out. But if it is positive, so you have to if it is positive HCV infection is there, so you have to repeat it after 3 years of age. Why after 3 years of age? Because 25 to 50% recover spontaneously. Okay, mother to child transmission, if HCV RNA is positive, it is 5 to 6%, and if HCV RNA is positive and along with HIV, the transmission rate is 10 to 20%. Okay, I'm understanding this lecture is going very heavy and very heavy for your brain, and it is lot of information is concised. So, but as we are all pediatricians, so this much knowledge grasping is required for understanding infections in unit. I'm just relaxing you guys a bit. So just if you haven't subscribed my channel till now, do subscribe and share this channel in your college or WhatsApp or Telegram groups, and when where other students are there. Okay, so we'll cover whole this neonatology. We'll try to cover neonatology before exam, as many as topics as I can do, and after exam we'll do something with like Nelson part. We'll do other thing. I'll announce it later, but for Nelson general pediatric we'll do something after this exam. Okay, so let's coming back to topic. Okay, syphilis. Syphilis actually this is important. Just understand this is actually exhaustive looking, confusing table is there, but what you have to do in this, just understand. Testing of syphilis is done all pregnant women. It is clear. Okay. So if in high risk cases, generally this testing is repeated at 28 week of gestation or at delivery. Generally it is repeated in high risk cases. Okay. So routine screening of syphilis in neonates is not required. Very much important statement. So in mother, VDRL, RPR or TPHA, FT, ABS you have to do. Okay. So this test you did in mother came out to be syphilis positive. What you will do next? Okay. Obviously, you will examine the neonate, placenta, umbilical cord. You will do dark field microscopy of suspicion lesions or body fluid, clinical examination for evidence of syphilis like non-immune eye drops, anemia, jaundice, hepatosplenomegaly, rhinitis, skin rashes, pseudo-paralysis. Very important. Okay, so you have to be well thorough with clinical features of syphilis in neonates. Again, I'm repeating it. Non-immune hydrops, anemia, jaundice, hepatosplenomegaly, rhinitis, skin rash, and pseudo-paralysis. And one more important thing to consider, VDRL RPR is not VDRL RPR is done, but no need of TPHA and FTA ABS test in units. Okay, So you did clinical examination and you did this VDRL RPA titers. Okay. Now, how you will go forward with this? Okay. There are many case scenarios. Okay. These case scenarios are very simple. We'll discuss them in like detail. So these are two scenarios basically. So here we discuss two scenarios. Others are just. So first is proven or highly probable disease. Okay. So presence of any one of three, like physical abnormalities as we discussed, VDRL titer is more than 4 times of mother titer and positive dark field test. Any one of three should be positive. It is proven case of neonatal syphilis. What you will do, just you will do two things: aqueous crystalline penicillin G or procaine penicillin G. These are only two drugs to start with. So the dosing is like 1.1 to 1.5 lakhs, sorry, 1 to 1.5 lakhs units per kg per day IV for 10 days. Okay, and after that 50,000 units per kg per dose every 12 hours during first 7 days of life. After it is 8 hourly. Okay, so this is the general regimen. You have to remember this. Procaine penicillin is other drug which is used at 50,000 units per kg per dose. IM in single daily dose for 10 days. So you have to see this is single daily dose IM for 10 days. Okay, possible scenario like all of three should be there, not one of three, all of three. Normal physical examination, VDRL titer is less than 4 of maternal titer. Mother is not treated, inadequately treated. In this case scenario, just remember with me, just give patient benzathrin penicillin 50,000 units per kg dose IM in a single dose, not for 10 days. So benzathrin penicillin 50,000 single dose give to the patient. Okay. But if less likely means presence of all three. So all three means normal examination, VDRL less than 4 and mother is adequately treated as we discussed also. Okay. In this condition also just uh, stay here. Oh, sorry. Benzathrin penicillin 50,000 units per kg, a single IM injection. And if congenital syphilis unlikely, everything is normal, again, no treatment is required, but for safer side, same benzathrin penicillin is required. So this looks confusing, but this is super easy. Just pay your attention here. Treatment if syphilis is proven, you have to give aqueous penicillin G or procaine penicillin G for 10 days. Clear cut answer. Possible, sorry, possible, less likely or unlikely case scenarios in this condition. The benzathine penicillin is safer choice. 50,000 units per kg IM single dose is required. So this is how we will go forward to syphilis treatment. Very important. Okay, so what is the most common clinical features of congenital syphilis in neonatal period? This is, my dear friend, hepatomegaly is most common with or without hepatosplenomegaly, 60 to 100% cases. Radiographic changes you will see periostitis, osteochondritis and pseudoparalysis of parrot in 75 to 100% cases. This is ciliary stocking and widening of metaphysis in long bone is seen. This is classical of this syphilis finding. Okay, jaundice will be seen in 50 to 70%. Skin rash 40%, along with desquamation you are able to see. Other things are there. Non-immune hydrops is 5%, rhinitis and myocarditis, nephrotic syndrome, or cerebral infarction, seizure are rare complication of this congenital syphilis and neonatal period. So this is important. Okay, going forward to toxoplasma. Okay, we'll cover all infections. Don't worry. Okay, so this will be your one-stop solution for neonatal infection, including neonatal sepsis and congenital infections, which is a major chunk of our neonatology. Okay, so it is taking time, but stay with me. It will be beneficial for you. Okay, don't leave if you have reached till now. So, neonatal infection with toxoplasma in pregnancy, if your gestation is less than 18 weeks, you have to treat mother spiromycin. Okay, spiramycin, sorry, spiramycin. You have to treat mother if your gestation is less than 18, but if gestation is more than 18, or positive amniotic fluid PCR or affected fetus, anything is there. So you can't treat mother, but maternal treatment with pyrimethamine, sulfadiazine and folinic acid. So there are two drugs before 18 week. It is actually spiramycin. After 18 week, it is trimethoprim and sulfadiazine and folinic acid. So this you have to remember. When your newborn is born, just evaluate him and do IgM, IgA, IgG. Okay, if these are positive, like IgM generally comes positive after 5 days, IgA just come positive after 10 days, and IgG, if they are all positive, you have can safely say diagnosis of congenital toxoplasmosis is confirmed. Okay, negative cases are followed by IgG. Okay, so you did USG, CSF examination, all that. I'm not going into that detail. Okay, if you found your normal evaluation is there, so you have to follow up with serial IgG titer for 4 to 6 weeks. After monitoring of 4 to 6 week of IgG titers, if it is negative, it is negative. But if it is positive, it will be called as congenital infection. So how you will treat the infant? You will treat the infant for 12 months, 1 year with pyrimethamine and sulfadiazine, add folinic acid and follow neutropenia. So how you will follow up neuro eye examination for 3 months till 2 years of age, 6 monthly in third year, annual in adolescence. Till adolescence you have to do neuro examination, eye examination. So this follow up part is important as treatment part. So as for treatment consideration, pyrimethamine sulfadiazine plus folinic acid is used treatment in neonate along with mother after 18 week of gestation and positive fetus. This is crux of toxoplasmosis. Okay. Next we are coming to cytomegalovirus. Okay. So, congenital cytomegalovirus infection is considered if any one of the positive symptomatic disease is there. You have to diagnose like IUGR, jaundice, hepatosplenomegaly, microcephaly, etc. Abnormal imaging, like you found periventricular calcification, it is there. Classical finding is there. Diagnose CMV. Okay. Abnormal fetal ultrasound, echogenic bowel, IUGR, this is congenital CMV and born to mother of CMV infection during pregnancy. Okay, so in this condition, this is diagnostic consideration means you provisionally diagnose this must be case of CMV, but again you have to confirm it. Okay, so for confirmation, what you will do, urine or saliva PCR within first 3 weeks. Just see, we are not taking blood, we are taking urine or saliva. We will do PCR within first 3 weeks of life. If it is negative, any other thing you have to do? No, infection is ruled out, my dear friend. But if your urine saliva PCR is positive, it is congenital CMV infection. Again, like other infections, you have to do physical examination, CBC, LFT, USG cranium, etc. Okay. If then after examination you found your neonate has no symptom, mild symptom, or very important, isolated sensorineural hearing loss. So just you have to follow for 2 years. 90% are asymptomatic and 15% develop SNHL within first 2 years of life. So isolated SN hearing loss is not a also general condition. You have to follow up the patient, but symptoms are more. Your patient is bilateral SN hearing loss. In this condition, it is moderate to severe symptomatic congenital infection. So what you have to do, In this case scenario, you have to do clinical examination, CNS examination, and CMV, DNA, and CSF. If you found this is symptomatic severe infection criteria. Okay, in this condition, treat with oral valganciclovir. It is preferred. So, preferred drug of choice of treatment of CMV infection, that is congenital, is oral valganciclovir. It is preferred. What is the dosing regimen? The regimen we have discussed earlier also. 16 milligram per kg per dose every 12 hourly. Okay, or IV ganciclovir is used for 6 months, 6 milligram per kg per dose every 12 hourly. So this is all about CMV infection, how you will proceed with diagnosis and treatment. Okay, varicella infection. So this is important. Before varicella, I just want to discuss varicella zoster. Varicella zoster, just I'm giving things. In varicella zoster, no isolation is required and no varicella zoster immunoglobulin is required. Okay, so forget it, varicella zoster. Now we'll discuss varicella as such. So what are the important days which can cause maternal rash onset in respect to birth of baby which are severe? So 5 days before birth and 2 days after birth, this 7 days window, 5 days before and 2 days after, it is critical. In this condition, likelihood of neonatal infection is high. This is very important. So you have to, we'll discuss this, we are discussing this limb. So in this case scenario, you have to separate mother and neonate until maternal lesions are crusted and dried up. Okay, so you have to painfully separate mother from baby till maternal lesions are dried up. Okay, if neonate develop rash, so it is supposed to having a disease. So both neonate is having disease and mother is having disease. So you can actually keep them in a single room or along with mother. This is what is the treatment. Varicella zoster immunoglobulin of immunoglobulin is not available. IVIG you have to give within 72 hours of exposure along with IV acyclovir. If neonate develop varicella of any severity means pneumonia, encephalitis, thrombocytopenia, and severe hepatomegaly. Okay, so I am focusing on this limb. Actually, you have to separate mother from the child, and if child is developing rash, keep him or her with mother along with give him varicella zoster immunoglobulin. Acyclovir is indicated only in case of severe varicella. Okay, coming from this limb, if uh, before like 5 days of birth, generally severity is low, you have to isolate dyad from the other mother and neonates. Basically, mother and neonate separation is required along mother and unit dyad. Okay, so varicella zoster immunoglobulin is not given, but acyclovir is given if it is disseminated or severe. So acyclovir dose we'll discuss. It is 10 milligram per kg per dose every 8 hourly, means 30 milligram per kg per day for 10 days. Okay, after if it developed after 3 days, it is also simple, acyclovir is given. Okay, so now we'll discuss dose of varicella zoster immunoglobulin if it is available. So you have to remember this also. If weight is less than 2 kg, the dose should be 62.5 international intramuscularly. If the weight of neonate is more than 2 kg, it is 125 international intramuscular. IVIG dosing is 400 milligram per kg. Both you have to give within 10 days of exposure. Okay, if your exposure is there, so isolation duration is recommended. If a patient took IVIG, isolation is 8 to 12, 8 to 21 days, starting from 8 days to 21 days after rash, obviously, and no IVIG given, no immunoglobulin is given. 8 days to 28 days the isolation period. If your infant is exposed, infant is less than 28 week, regardless of maternal history, give varicella zoster immunoglobulin. If your neonate is 28 to 36 week of gestation and no maternal history is there, you have to give varicella zoster immunoglobulin. But your infant is neonate is more than 37 week, no need of giving varicella zoster immunoglobulin. Basically, in preterm neonates, you have to give varicella zoster immunoglobulin after exposure, not in term neonate isolation period we have discussed. Okay. Now, active herpes genital lesions. Okay, so stay with me. This is actually vital to discuss all these infection in a row. Okay, so you will be able to differentiate them with another infection. Okay, so, herpes genital infections in this condition, differential, what you have to see, maternal infection you have to see. So, primary or non-primary maternal infection is there, you have to see differential serotypes. So, in this clinical examination, you have to see HSV, blood PCR, CSF cell counts, ALT, platelet count. So, in this condition, start acyclovir at 20 mg per kg per dose 8 hourly. So, in that HS we have seen the dose was 10 milligram per kg per dose, but herpes genitalis, genital lesions, the dose is 20 milligram per kg per dose 8 hourly. If recurrent infection is there, obtain all HSV surface culture. Surface culture are like conjunctiva, mouth, nasopharynx, rectum. If they are both negative, follow up then 6 week. So if infant is asymptomatic, CSF ALT is normal, okay, PCR culture is negative after doing all examination. So in this condition, preemptive therapy for 10 days of oral acyclovir and acyclovir suppression is not required. So just give acyclovir 10 days and that's it. But if your uh, patient is symptomatic, CSF is positive, and ALT is abnormal, and PCR or culture is positive, you have to treat skin, eye, mouth disease for 14 days, my dear friend. But if it is CNS or disseminated disease, you have to treat them for 21 days. So, what is dissemination in case of active herpes genital lesions? In this condition, fever, rash, de-icing, hepatomegaly is considered. Okay, repeat CSF PCR at the end of therapy. If it is positive, continue acyclovir for additional 7 days. But if it is negative, you have to give acyclovir suppression therapy. We have discussed the dose of acyclovir suppression therapy. It should be 300 milligram per meter square per dose in 3 divided doses daily for 6 months of age. So this was herpes genital infection. Okay, so this is how we covered these actually congenital infections. Just pause this video here and revise them once for all, because this is actually you are in a flow, and you can revise them in a flow, and trust me, this is ultra important high yield topic. Even you are first year resident, second year resident, third year resident, practicing physician, or giving your exam NEET SS or INSS, this will remain true to all your spectrum of your pediatric journey. Okay, so clear them once for all. Okay, we'll discuss fungal infections now. Okay, so fungal infections, 25% of fungal infections are due to candida. Okay, so candida is more common in outborn, LBW, and preterm. Out of candida infections, candida albicans is most common organism, which is found in 50% of candida infections. Second one in is candida parapesolosis. This is 33%. Other are candida glabrata, cruzi, and tropicalis. So this is generally organism overview. What are the risk factors? Okay, we have to consider risk factors also. Extreme prematurity we know, ALBW we know. Prolonged antibiotic uses more than 5 days. Just remember, this is a risk factor for a fungal infection. Usage of more than 2 antibiotics in sepsis is also risk factor. Use of H2 blockers, right? Ranitidine, hyperglycemia. Parental lipid infusion for more than 7 days. PPIs and postnatal steroid, not prenatal, postnatal steroid, all are the risk factor for fungal infections. Okay, how you will diagnose? So blood culture is diagnostic. So as we discussed, blood culture is gold standard because 90% of fungi grow in 72 hours of age, 72 hours of incubation, but you have to monitor for 10 days for late growing funguses. Urine culture in this condition, 10 days for 4 CFU per ml in catheter sample, it is positive, and more than 1000 CFU in suprapubic sample, it is positive. CSF examination is must in all bloodstream fungal infection. PYQ question. Culture from other side you have to take. Okay, so candida in ET aspirate, generally we see in our NIC units, it is not reliable, not to be done. Okay, and organ dissemination screening in all bloodstream infection should be done. This is very important, practical, beautiful case scenario. You have to, if you are suspecting fungal infection, eye examination, ophthalmitis, retinitis, renal USG for fungal ball, blood echo you have to do, and cranial nerve examination you have to do. Okay, so and neuroimaging you have to do. So this is actually end organ dissemination screening you have to do. Okay, newer diagnostic methods like PCR, beta 1,3-D glucane, yeast traffic light assay, this is PNA, FISH. So these are newer experimental, generally we don't do in our routine clinical practice. So, treatment. Generally, fluconazole amphotericin B is used for this treatment, but just some pointers are there. Candida glabrata and Candida krusei are resistant to fluconazole. Candida leucitenine is resistant to amphotericin B. So, this you have to remember. So for systemic candidiasis, what is the drug of choice? It is amphotericin B deoxycholate. Okay, lipid formulation of amphotericin B is used. This actually having lipid formulation of amphotericin B having decreased concentration in kidneys and lungs. That's why it is less effective in UTI. So liposomal amphotericin B is used. This is also PYQ. So lipid formulation of amphotericin B are not used in UTI fungal infections. For meningitis, what you have to do? Add flucytosine 25 milligram per kg for fungal meningitis, very important, and duration is 2 week for bloodstream infection, 3 week for meningitis, again very much important. Okay, so drugs, you have to remember some doses also, like amphotericin B, the dose is 1 milligram per kg per day IV every 24 hours. Toxicity, renal. Lipid formulation of amphotericin B is 3 to 5 milligram per kg per day IV every 24 hourly. Okay, so primary concern of use of fluconazole is due to emergence of resistance of Candida krusei and Candida glabrata, because these are resistant to fluconazole. So liberal use of fluconazole should be avoided. If central venous catheter is there and fungal infection is suspected, you have to give antifungal dose through old CVC, remove them and send tip culture, and if required, put another fresh CVC for this. This is simple guidelines. Okay. So amphotericin B, we have discussed this. This is nothing new. Amphotericin B dose is same. We have discussed liposomal amphotericin B. We have discussed also. So this is nothing new. Fluconazole dose we have discussed. Okay. So how you will prevent this? Okay. So antifungal prophylaxis in NICUs. So what you have to do? Intravenous or oral fluconazole prophylaxis 3 to 6 milligram twice daily for 6 weeks in all ELBW infant. Generally, we usually give. Avoid broad spectrum antibiotics in NICU until required. Okay, not using more than 2 antibiotics simultaneously, obviously. Avoid use of PPI and H2 blockers. Okay, early extubation to CPAP, early enteral feeding, and restricting postnatal steroid use because those are risk factors and we have to avoid risk factors for prevention. Okay, outbreak generally happen in nursery and ICUs. Okay, so Klebsiella outbreak, if it is occurring, it is due to low birth weight, prolonged hospital stay, multiple antibiotic use. MRSA outbreak is happening even in an ICU. So the colonization of anterior nerves may be seen in up to 30% of patient and healthcare workers that can lead to MRSA outbreak. Pseudomonas outbreak because it loves humidity of incubators and other overcrowding multiple dose medicines. So it prevents biofilm and may colonize hands of healthcare worker. Okay, Serratia. So this is nowadays emerging pathogen. This is due to contamination stock solution. So this is one of the Candida species. So this is TPN, central venous catheter, NEC condition. You can see this. Okay. So just I'm giving some tables for your revision for these infections, which are from standard textbook like Nelson, which is important because line can be asked as such in examination. So CMV exam, I will highlight important question. CMV, avoid direct contact with toddler urine saliva. Okay, this is prevention strategy. Varicella zoster virus vaccination. So vaccination of mother is available for varicella zoster, okay, rubella and COVID. So this small cute question can be asked. Vaccination for mother is available for these condition. So as we discussed, for rubella, maternal vaccination is required. Zika, prevention of mosquito bites. Toxoplasma, avoid undercooked meat, avoid unpasteurized goat milk, avoid raw mollusk, avoid contact with litter and soil potentially contaminated with cat urine or feces. This is important. This question directly can be asked. Okay, again we have discussed, just be with me. In Toxoplasma hydrocephalus, okay, rubella virus, blueberry muffin, and disturbance in bone growth and intrauterine restriction. I am giving these tables because many questions are directly picked up from these lines. So that's how it is important to discuss them. CMV, microcephaly, periventricular calcification. Okay, HSV, vesicular rashes, keratoconjunctivitis. VZV, varicella zoster, limb hypoplasia, cicatrial skill lesions, and ocular abnormalities are seen. HIV, calcification of basal ganglia, again very important. Zika virus, just see microcephaly, lissencephaly, cerebellar hypoplasia, Echinus syndrome, macular scarring, retinal mottling, subcortical calcification, hypertonia. So these are so much of it. Okay, late sequelae of intrauterine infection like hearing loss is seen in almost CMV, rubella, toxoplasma, treponema, and Zika, and other like developmental delay in seizures can occur in all these conditions. So this you have to measure late sequelae. They can ask hearing loss, dental skeletal problems, developmental delay, and seizures. Okay. Triple I, we have discussed the triple I also. This is now a hot favorite topic of examiners. So triple I, how we will confirm triple I? So amniocentesis proven infection through positive gram stain, okay, low glucose of amniotic fluid or positive amniotic blood culture, placental pathology consistent with infection. All of the above should be present for this triple I. Okay, so this is actually last table of this. Some laboratory tests and diagnosis. So this is just a recap of what we have learned. So chlamydia, DFA culture using special transport media, Neisseria, like we have discussed, gram-negative intracellular diplococci,
Syphilis, we have discussed RPR and VDRL. Cytomegalovirus, we have discussed urine, saliva, and confirmation of CSF. Hepatitis B, we have discussed at 9 months of age and hepatitis B surface antibodies. HSV have discussed surface cultures. Okay, we have discussed it. Zika, blood and urine. SARS, we all know. SARS or COVID. This is nasopharynx, oropharynx, nose, saliva, trachea. So basically, this is a recap of what we have discussed. So this is actually we have completed this exhaustive topics of neonatal infections. Hope you like this video. If you are till here of this video, do share, like, and subscribe. And actually, this for sharing purpose, I'm telling you, please share this in your wider group of your residents, your peer groups, your WhatsApp groups, or basically. It is taking a lot of effort to making these videos, so do share and please pin down your comments down below how your this revision series is going on, what other things you require. It should be interactive. It should not be just like I'm teaching and you are just listening. It should be interactive. For this particular lecture point of view, just revise it once again and it will be beneficial for your everything, for your exam and your clinical practice point.